Yes.
Go ahead. Thank you.
Okay. Thank you so much for this kind invitation. Also, I would like to thank Professor Cilo. And for me, it's a great honor to have the opportunity to close the meeting. So my talk aimed to summarize, I hope in a logical way, some concepts that have been previously displayed by the other speakers. And the intention is to discuss with you what is the transplant hepatologist point of view regarding the indication and the rapid changes in the indications for liver transplantations. So, as you know, for many, many years, the BCLC algorithm dictated the indications for liver transplantation according to the stages of the HCC, reserving transplant to those patients who present very early stage of HCC, associated with increased portal pressure and with increased risk for surgical resection, or those for having early stage of HCC, which was based on the Milan criteria for selected patients for transplant. So the benchmark criteria developed after the Milan criteria published in 1996, which displayed very clearly that if we select patients to transplant on the basis of pure morphological criteria, such as the number and the size of the nodules, we are available to select patients with an excellent overall survival after transplantation and with a low risk of recurrence. But going into down of this data, it appears clearly that morphological criteria upfront were not so sufficient to discriminate patients with better compared to those with a worse survival, because at the histological evaluation, patients who do not meet criteria originally observed pre-transplant show a clear worse overall survival related to the high risk of recurrence. So the question was, is the umbrella of the Milan criteria too narrow? In other words, we can go outside to the Milan criteria without increasing the risk to reign of ourselves. And this is the very important thing that was associated with the development of new criteria to select patients for transplant. For example, adding some biological parameters such as alpha-fetoprotein to tumor morphology, or downstage the tumor, which upfront present without Milan criteria, and to downstaging it within Milan criteria, and also to evaluate the stability of tumor downstaging before liver transplant. So this concept appears in the last version of the BCLC scheme, which indicates that liver transplantation can be considered in patients with intermediate stage of HCC, considering extended liver transplant criteria, for example, based on the size and the AFP serum levels. So the model considers also that liver transplant can be offered to patients in whom a successful downstaging of the original tumor has been achieved by local, regional, or systemic treatments. What is the real scenario in patients who had HCC, at least in Italy? This is a very beautiful study performed by the Italica database, including more than 2,000 of patients, in which appears clearly that we have two populations affected by the HCC. The first one on the right of the slide is the population who developed HCC during a surveillance program, for example, in patients with chronic hepatitis B or chronic hepatitis C. And the other, the other population is also the population in which HCC developed outside of the surveillance program, for example, in patients with alcoholic liver disease, and most importantly, and increasing in prevalence in patients who had steatohepatitis. So only 55% of patients in Italy presented HCC in the very early stage following the BCLC criteria, and at least 15% of patients developed HCC with an intermediate stage. So the problem is how to offer to these patients, which are in the intermediate stage, a real option to get a liver transplant. This is an example of clinical practice, how patients with BCLC-B can present to the hepatologist, to the surgeon, to the gastroenterologist. This patient could have a single lesion with 6 centimeters in diameter, or 3 lesions with the higher size of 3.5 centimeters, or multinodular disease on the liver. Are we sure that all these 3 patients should be treated with TACE? Probably no, because the first one could be treated with surgical resection or with radioembolization. The second one with 3, for example, radiofrequency ablations, and the last one with systemic chemotherapy. The real changing in the paradigm to select patients for liver transplantation on the basis of criteria have been developed, as Professor Cielo said previously, by the concept of therapeutic hierarchy for HCC. Because, as you can see clearly in this slide, besides the stage of the HCC, the liver transplantation option for treatment is associated for all these stages, at least up to B2 stage, with a better survival compared to the all other treatment options that are mentioned in the BCLC scheme. So, considering this paradigm that have changed completely the rules to select patients for liver transplantation, in the recent years, the criteria to select these patients moved from tumor morphology to other markers, for example, biological markers. And one of the most important advantage in this kind of selection processes has been done by the MetroTicket 2.0 model. In this model, you can see that if we select patients with an expanded number and size of number of the nodules compared to the original model of the Milan criteria, and this new model is the up to 7 criteria, and you add to the up to 7 criteria a biological marker of invasiveness of tumor as the alpha-fetoprotein, you can select patients combining these 2 parameters. On the one side, the number and the size of the nodules, and the other one, the alpha-fetoprotein levels. It appears clearly that if you have an alpha-fetoprotein higher than 1,000 nanogram per milliliters, probably this is a threshold above that at the front line, transplant benefit could be null or extremely lower. It appears clearly that if you select patients considering as continuous variables the alpha-fetoprotein levels, you can select two different populations. The first one with alpha-fetoprotein up to 7 criteria in, compared to those who are out of these parameters. And these two populations differ significantly in terms of overall survival and in terms of recurrence-free survival. And this model performed better to the other models previously displayed in the literature. But the model is based on the upfront presentation of the tumor, alpha-fetoprotein levels, size and numbers of the nodules. Is this sufficient to select properly patients for transplant? Probably no, because we have another option to select this patient that is a dynamic option, not a static option as the upfront presentation of the tumor. And this is the concept of downstaging to select post-downstaging treatment candidacy for patients for liver transplant. We do not confound the neoadjuvant treatment with the downstaging treatment, because if you apply the concept of downstaging treatment before transplantation, this means to bring patients whose tumor burden is outside accepted criteria for transplant to within accepted criteria, and to select patients with good long-term outcomes among poor risk to recurrence. This is probably related to the response of treatment and the observation time used as surrogate markers for favorable biology of the tumor. So, which are the downstaging modalities that we can apply to these patients? There are conventional downstaging modalities such as TACE, ablation, radioembolization, and more interesting stereotactic body radiation treatment, and many data on this are coming in the literature. And applying these very well kinds of downstaging strategies, the models improve further to consider response to downstaging treatment as the very important marker to aggressiveness of tumor and to be considered for select patients outside Milan criteria for transplant. It appears clearly that on the basis of response to downstaging treatment, complete, partial, stable disease, progression disease, the cumulative incidence of waitlist dropout was significantly higher. So the evaluation to response to downstaging treatment and the observation period is a really good option to select patients who may benefit from liver transplant from those who had a very rapid waitlist dropout. Similarly, the same could be applied if we evaluate the recurrence rate after liver transplantation regarding to the type of response during downstaging treatment. And you can see that patients who had complete response during downstaging treatment in the waiting list present a significantly lower rate of recurrence after transplant. These are the basis and the conceptual basis to have the need to design studies prospectively to evaluate the impact of downstaging treatment for select patients outside Milan criteria for transplant. And this is the first randomized trial who select patients the majority of them outside of up to 7 criteria, all of them outside 2 Milan criteria upfront, and to apply for them strategies to downstage the tumor based on the local regional therapies, on the systemic therapies, in this case only sorafenib. And it appears clearly that patients who had a good downstaging on the tumor during the waiting list and have been transplanted presented a significantly higher survival, both in terms of overall survival and in terms of tumor-free recurrent survival, compared to those who don't achieve a sustainable downstaging during the waiting list. So post-downstaging tumor response could contribute to the expansion criteria for HCC. So successful downstaging has been incorporated in the new version of the BCLC model that have been updated compared to the original very, very rigid model. So what are the strategies that are incoming and that we are using today to downstage patients with a multinodular disease in the liver? Obviously, there are the systemic drugs, TKIs and checkpoint inhibitors plus TKIs, or combination for systemic drugs plus other techniques. This is an example of how patients with the HCC developing MAFL disease get a resection with a good results in terms of drop of alpha-fetoprotein, but after 8 months of resection, alpha-fetoprotein go up rapidly, and the tumor reappear in the liver, and at that point, this patient start treatment with atezo plus bev, and as you can see, after a few months of treatment, the tumor mass was completely devascularized, and the alpha-fetoprotein level drops down. So this is an example how immunotherapy can convert a tumor that at the baseline is completely outside for criteria to transplant to a very incredible response to treatment. The main concerns in adopting immunotherapy in the setting of liver transplant, as Martina said before, are many and can be divided in who to offer immunotherapy to, for example, within criteria with intention to bridge to transplant, or beyond criteria with intention to downstage for transplant. And the problem is how much beyond. Conversion treatment is the key issue of this concept. However, we can consider the risk of rejection employing the immunotherapy, as Martina previously says, and risk of HCC recurrence when we expand the criteria to offer to patients liver transplant. Finally, risk of transplanting patients with long-lasting complete response is another key issue. In other words, are we sure that a complete response to immunotherapy will be only temporary or will definitive? So in the first case, we probably should transplant the patient. In the second case, probably not. These are some examples of how to employ systemic treatment with immune checkpoint inhibitors before liver transplant in patients out of Milan, and many of them out of also of up to 7 criteria has been employed, and none of them experienced rejection after liver transplantation, with a median time to the last immunotherapy administration and liver transplantation ranging from 46 to more than 250 days in the world experience. This is an example of how we should more evaluate in detail the response to immunotherapy employed in the pre-liver transplant setting by means of studies designed and dedicated prospectively to evaluate this very important issue. This is an example of one of the many studies that are ongoing around the world, evaluating the downstaging with immunotherapy in patients, candidates to liver transplantation will present at the upfront criteria that are outside those reported by Milan criteria. So in the summary, I think that liver transplantation remains the mainstay treatment for HCC in patients with cirrhosis. The paradigm to select patients with HCC for liver transplant moved below Milan criteria. This is a very important point because many patients who had HCC are taking the care for many specialists, oncologists, hepatologists, surgeons, gastroenterologists, and as Professor Cillo previously said, the risk is that a subset of these patients cannot be directed to the liver transplant programs because the concept that the liver transplant can be offered only for those who had HCC beyond Milan criteria. This concept is not yet possible to consider as a rigid rule. The composite criteria that considers surrogates of tumor biology and successful and durable downstaging with neoadjuvant treatment are likely to replace, in my mind, the conventional morphological criteria for defining transplant feasibility. And I think that the two last points are those that are more important to share with all our colleagues that are taking care of patients with HCC. The first one is that innovative systemic treatments could and should help in changing the transplant paradigm, allowing to consider all patients based on treatment response. And finally, if no clear contraindication to liver transplant are present upfront, ideally all patients should be discussed in a multidisciplinary team, including transplant hepatologists and transplant surgeon. Thank you so much for your attention.
Thank you. Thank you, Pierluigi, for the very clear talk. And you really, for the first time, as far as I can say, mentioned the fact that Milano criteria are not, the must anymore. And I think this is an important notice. And does anybody have a question to Pierluigi? Otherwise, I would ask a question. I mean, we know that, we deal with two diseases, the HCC and cirrhosis in most of the patients. But we didn't talk much about that. And I saw in one of your slides in a table, mild 7 to 9, and then child A, B, and C. So, I mean, mild is used, it's not the lab mild you use in the HCC, you use the match mild, right? So you start with 22 points, and which is not dependent on cirrhosis or not cirrhosis. It's just, according to the what you think could be the prognosis, and you gave that. So it doesn't have anything to do with cirrhosis, with the liver function in this case. So I don't understand why, it is, this is in the table, continue to be mild, 7 to 9, and suggesting that you use the mild as a liver function criteria. I'm right?
Yes, I fully agree with you, Giuliano, because MELD has been originally created to assess the risk of mortality after TIPS placement in patients with cirrhosis, and subsequently has been used to prioritize, to get a priority of patients to get a liver transplant. But it appears clearly that the MELD has not been a good system to equalize patients with and without HCC. It's clearly an imperfect tool to assess the severity of liver disease overall, and in particularly for patients with HCC. So there are many artificial things to equalize MELD in patients with HCC with the MELD with patients of patients with cirrhosis without HCC, with the intention to get the same probability to have been transplanted between these two populations. But the risk for dropout in patients with HCC is completely different from those who had liver cirrhosis. And I think that the MELD score should not be used to assess the severity of liver disease in patients with compensated cirrhosis and with HCC.
Thank you. Thank you. I also think about where you were talking about, you mentioned Mazzaferro, you know.
Yes.
People know the history of Italian HCC. Have to think that Mazzaferro is a surgeon of Istituto dei Tumori. He's not used to see patients with liver cirrhosis. I cannot remember how it was, the paper in 1998, you know, which I consider to be retrospective and not prospective. You know, at the end, he went through and looked at, you know, who had the best results, and, you know, found that the best were those at that time. But I don't think he ever got really a patient with decompensated cirrhosis. I may be wrong, but even Istituto dei Tumori, you get the patient, probably child A with the tumor, but not a cirrhotic with decompensated cirrhotic. So it would be another reason to check again what you said, you know, that one should think beyond those criteria, who lasted now for 25 years. Anybody else? Questions? Thank you. Thank you, Pierluigi. Thank you. Thanks a lot. If I understood right, this was the last talk